Thank you for joining us today. Um, so thank you, for taking the time to just like join us today. I'm very impressed by the number of registered participants. Let me first introduce myself. My name is Eli Karam. I'm a fourth year orthopedic surgery resident in Quebec City. I'm also a husband and a father for a 2-year-old princess. I'm also an AS warrior. I was diagnosed 2 years ago. It probably took around 4 years to get to this diagnosis. And I'm frankly grateful that I can now say that I've been almost pain-free for 18 months. I recently joined the board of the CSA, and I really hope that I'll be able to contribute with this great association to raising awareness about this disease and spondyloarthropathies in general. Um, so I'll get started here. So without the continued support for sure of many partners, we would not be able to bring information events like this one tonight. So thank you to all the partners. Um, so today's agenda, I'll be just like giving a brief overview of the CSA. Then I'll leave the presentation for Dr. Sun. We're all looking forward to this presentation. And we'll finish with a Q&A at the end. Please do leave us your messages, your questions. We'll take them all into consideration and we'll try to answer as many as possible at the end. So who are we? The CSA is a national association with the sole purpose to support those diagnosed with spondyloarthritic diseases. We are a federally registered not-for-profit corporation. We submitted an application for charitable status. We have currently 11 board members that are all volunteers, all living or affected by spondyloarthropathies. We have a great executive director, Wendy, and an awesome social media and IT expert. Thank you both so much for all the amazing work that you do every day. So what's the mission of the CSA? The mission is to be the leading voice for the spondyloarthritis community in Canada, providing support, education, advocacy, and awareness for patients, caregivers, loved ones, and healthcare professionals through innovation. We have 4 strategic pillars: education, information, advocacy, awareness, and support. We try to raise awareness through social media, community support, information sessions, webinars like this one, awareness through patients, public healthcare professionals, CSA branding also, and international awareness and community activities. So we continue to advocate for medication. Recently, we added, we're more involved in devices and services. And our healthcare system, as you all know, may sometimes be complicated. So we try to fill in the gap of lack of information and resources to the patients in order for them to, for example, understand how medications can be reimbursed. We try to continue to shape policies. And although we do not currently financially support research, we do support those who do research, as we truly believe that it is through research that we will ultimately have the greatest impact on patients. 3 years ago, we started support group. We only had 2 in Canada. We now have more than a dozen. I personally joined recently the Montreal support group, and I have to say, it was one of the most pleasant surprise of this awkward year. I got to listen to some amazing and inspiring stories, and share my worries, share my fears, and moments of joy with a group of amazing AS warriors. I'm truly grateful to have met them, and even if it was only virtually this year. So if anyone is interested in joining or starting a group, please do reach out to us, or send us an email, to support@spondylitis.ca. So we have a lot of upcoming events. On November 24th, Dr. Chan will be presenting on the treatment journey starting, at diagnosis. And we have a lot of, we have actually an excited lineup for 2021. Please do remember that we do not provide, we only provide information. This is not a medical advice. All the information presented here is only, presented and discussed, and it apply to your own conditions. So always discuss medical treatments, with your own, healthcare provider. Also, before turning it over to Dr. Sun, your feedback is important to us. So please, take 5 minutes at the end when we eventually send you, the survey, to just like fill it. It will help us, be better and get better. Um, so I'll turn it, over to Dr. Sun. A small brief presentation of Dr. Sun. Dr. Sun grew up in Surrey, British Columbia. He finished 3 years of honors, pharmacology as well as a minor in economics before entering UBC Medical School. After he graduated in 2006, he went on to train in the internal medicine residency program at UBC from 2010 to 2013, and the rheumatology fellowship from 2013 to 2015. He has a special interest in interventional pain procedures and chronic musculoskeletal pain management. Thus, Dr. Sun has a full spectrum rheumatology practice near Vancouver General Hospital, as well as practicing at, Change Pain. Thank you so much, Dr. Sun, for taking the time. We look forward for your presentation.
Great. Thank you, Eli. Thank you so much. So I'm just going to put on my presentation. It's going to be short, but then a lot of time for discussion at the end, and I'm going to, share my screen. So give me 1 sec. Can you see the presentation?
Yes.
Okay,
yes.
Perfect. I'll get started. So thank you for the introduction. I did do my, intermedicine at UBC Hospital. At UBC, I did rheumatology at UBC as well. I did an extra 1.5 years of interventional pain training, and I am on the Royal College Committee for Pain Medicine examination. So I was asked by Wendy to talk about pain management, and I think pain is something that we all suffer from, especially those with ankylosing spondylitis. The pain treatments I'm going to be talking to you about specifically are mainly about treatment of mechanical non-inflammatory pain. The difference being that for inflammatory type pain, where you wake up really stiff in the morning and you have this stiffness throughout the body, or peripheral joint swelling or peripheral joint pain, that type of pains are usually treated with biologics, small molecules. And so I'm not going to really touch up on that. A lot of patients, in addition to treatment with those biologics, will continue to have some mechanical type pain where it feels like a muscle spasm, muscle tightness, causes headaches, radiates down to the leg, difficulty with prolonged activity, pain that's a little bit opposite to their ankylosing spondylitis. And that is the pain that I will be touching on today in treatment. In terms of disclosures, I do do some research and receive honoraria from various drug companies. I will not be mentioning their products in today's presentation. So I think it is hard for me to give people an idea of how to treat chronic pain without giving them the breadth of complexity of chronic pains, how we get to that stage, and what are the different layers that we treat in this situation. So I'm going to talk about the complexity of pain management. We're going to talk about how I approach pain management, how to manage pain yourself mentally, and we're going to go through a quick Q&A. This is basically a very brief overview. If you have any questions, please speak to your specialist, your family doctor, or your healthcare professional about it, okay? Some of the issues here really pertains to BC to some degree, but the procedures and the treatment options are available to patients across the country. When we look at pain, we look at whether it is a neuropathic pain, which is shown here as nerve type damage, and we also differentiate into nociceptive pain, which, you know, these words are large words. Basically, it means pain that's not pain that's from an organ. Okay, pain that's from organs, pain that's due to, you know, tissue damage. When with neuropathic pain, we're more talking about nerve damage. The nerve becomes more sensitive. The spinal cord becomes more sensitive. And this is a very general differentiation of the mechanism of pain involved, but this speaks volumes down the road when we talk about how to manage pain, because ultimately in patients with chronic pain, it is not just one issue or one area that's causing a lot of pain. It's multiple issues that includes pain from the organs, pain from underlying mechanical receptors, to pain coming from the nerve, and coming from nerves being more sensitive. And so I'm going to be mentioning this sensitization concept quite often in my presentation because it is such a big part of chronic pain itself. So when I approach chronic pain, there's many different ways of approaching it. Some of you may have heard, oh, it's myofascial. Oh, it's chronic widespread pain. Oh, it's fibromyalgia. Oh, it's coming from the facet joint. Oh, it's ligaments, you know, all this kind of stuff. So how do we make sense of it? The way I do it is I go from an anatomical perspective from the outside in. When you tell me that, when the patient tells me they have pain in a certain area, I go from the outside. I say, okay, is it coming from the skin? For example, do they have shingles? Do they have a rash? Do they have a cut? Is it coming from the fascia and the muscles, so myofascial pain? You know, there's actually research now into the fascia, which is this thin layer of tissue that surrounds muscles, allows muscles to rub against each other. And there's actually receptors in the fascia that can actually transmit pressure type pain. And could those be causing the pain? Could it be coming from the ligaments? Could it be coming from the joints in the back, the facet joints or facet joints? Could it be coming from nerve root impingement? Could it be coming from the disc? So the way I look at pain management is I go from the outside in, so that way we consider all possible anatomical structures that could be causing pain. So again, this is an image of shingles. You can see that it's along the T5 dermatome, and shingles pain is a very neuropathic pain, right? So it goes back to the concept of, is this pain a mechanical somatic pain, or is this more of a neuropathic pain? Well, in this case, we have pain coming from the skin tissue, having the vesicles, having the rash, but we also have nerve that releases the vessels, that releases the virus, becoming sensitive, becoming painful. So this is a classic example of where you have pain coming from both areas. And in this case, the nerve pain is the predominant feature because patients with shingles will feel a lot of tingling, numbness, burning. They will feel that when they touch the skin, it's very sensitive to any type of light touch. Any type of stimulation that used to not cause pain would cause pain in that specific area. So that's a classic example of nerve pain with some somatic pain. Myofascial pain. So this is images taken from Simmons and Travell. They're physiatrists. They used to be personal physicians of John F. Kennedy, and they gave this nomenclature of myofascial pain, meaning that pain coming from the muscles. And what they found was that pain coming from certain muscles actually did not produce pain over the muscle all the time. It can actually radiate down. So pain from the lumbar spine muscles can actually radiate down to the buttocks. Pain from the tensor fascia lata or gluteus medius can actually radiate down the lateral side of the leg. Pain also from the tensor fascia lata or glute minimus can radiate to the buttocks and down the back of the leg. So what they're saying is patients have these myofascial type mechanical pains, and they can certainly radiate to areas that's outside of where the pain we think originated from that muscle. So facet joints. Facet joints are these joints that basically hold the spine in place. It prevents the spine from rotating too much. It prevents the spine from moving forward too much. It prevents the spine from flexing to one side or another too much, in addition to the ligaments that hold the spine together. Like any joints, facet joints can actually become degenerated and they can cause pain. And this was shown by various studies by a gentleman called Bogduk back in the 1980s in Australia. And what he found was that different joints on the neck, when it is aggravated, when they are painful, produces a specific pain pattern on the outside of the neck. Specifically, for example, if you have irritation of the cervical C3 and C4 facet joints, it really produces pain in this area of the neck in many of the volunteer patients who undergone this procedure. What's interesting is that if you actually have irritation of the facet joints in the upper spine, it can actually cause headache. And this headache can actually radiate up to the head as well. And when you have irritation of the facet joints in the lower neck, it can actually cause pain to transmit down to the posterior shoulder and into the scapular region. So again, the pain can be referred from the facet joints to various areas in the neck, and through their studies, they've tentatively guessed that most patients would have this type of pain distribution. The same thing can happen in the lumbar spine, and the facet joints in the lumbar spine can be aggravated, and it can produce various different pain patterns all the way down to the feet, all the way down to the ankles as well. And these joints can undergo osteoarthritis. Sometimes when you have ankylosing spondylitis, you can actually have inflammation of these joints, and that can cause stiffness in the back as well. But I want you guys to see how the pain in one area in one joint can actually radiate down the leg to other areas farther away from the joint in itself. Sacroiliac joints. This is a study where they put injection into the sacroiliac ligaments and sacroiliac joints, and they try to ask patients where they feel their pain radiates to. And in these cases, it radiates down the leg as well, and in some cases can radiate down to the heel and to the foot as well. So a lot of times this pain can be referred down the leg, even though we're stimulating the sacroiliac joint. And then you've got a nerve pinch, or sciatica as people call it, where a nerve is being pinched. Most commonly, it's the L5 nerve or the S1 nerve, and it can radiate down the leg to the heel, or it can radiate down to the hand, to the thumb, depending on the distribution of the neck. So as you can see here, S1, nerve root impingement, it goes down to the heel. L5, it goes down to the toe. L4, it goes down to the shins. L3 kind of goes down to the anterior knee. So then, the reason why I'm showing you guys all of these different pain radiation patterns from these different pain areas is mainly to drive home the fact that you can have a lot of different areas causing pain in the lumbar spine, in the cervical spine, in various areas that will have a referred pain pattern that is much farther away than what you expect the pain to be localized to. And when you look at nerve root impingement pattern, sacroiliac joint pattern, lumbar facet joint pattern, myofascial muscle pain pattern, the common theme is that the radiation can be very similar. And so it can be very, very difficult, as you can imagine, to tease out exactly where the pain, this chronic pain, is coming from in these patients. To further complicate issues, in pain medicine, we talk about acute pain pathway and chronic pain pathway. And arbitrarily, we set patients with pain less than 3 months as acute pain, over 3 months as chronic pain. It's a very arbitrary number. But when you have acute pain, for example, you stub your toe, you cut your finger, you have a paper cut, you can actually feel exactly where the pain is coming from. That's the acute pain pathway. It's a straight road down a path. You can feel exactly where the pain is coming from. You can localize it to that area. But that's not what happens in chronic pain. Over time, the pain pathways tend to evolve. It tends to progress. It tends to become more widespread. So instead of having a very, very clean highway down a grass field where the pain signal is coming from an area of injury, in chronic pain, you have a superhighway. The pain signals go everywhere. And that's why in some of these patients, when you start having pain in one area, initially you're able to localize it very well. But over time, the pain tends to spread. And it tends to spread from the area of initial injury. And it starts in some patients to include the entire lower back, the buttocks. It may include on the other side. It's because the pain pathway evolves, it spreads, and the pain signaling that you originally felt from that one single area has now spanned multiple spinal cord levels, and you feel in your brain as multiple areas of pain, not just that one specific one. And that's why a lot of patients with chronic pain, when you ask them, show me where your pain is, it can be very difficult because to them, their pain signal is like a highway, like a super highway. They feel it in that general area. Another analogy that I like to use is if you have a paper cut in your thumb, you can feel specifically pain coming from that paper cut. But let's say you don't let it heal. Let's say that you keep on poking at it, you keep on aggravating it. Then over a matter of days, maybe even a week, it's not just that one cut that's bothering you, your entire thumb will be throbbing. And that's also the concept of this chronic pain pathway. And the importance of the chronic pain pathway is that it's no longer purely because of damage to the tissue that's causing pain. In the chronic pain pathway, what we have is increased sensitivity of the nervous system. The nerves around the initial point of injury has become more sensitive. And in turn, the nerves that innervate the spinal cord has become more sensitive, and the spinal cord itself in that area that's being innervated by the nerve has become more sensitive. So you have this peripheral nervous system sensitivity, and you have this central nervous system sensitivity. And so patients can feel pain even when the original injury has healed. So when we look at this sensitivity, we also have to understand the concept of central sensitization. And this is dealing with patients previously called fibromyalgia, but not specifically fibromyalgia. It's patients where they feel pain all over the body, or they feel consistent pain in one area with no signs of tissue damage, nothing to show where the pain is coming from, and the tissues around that one area where their whole body has become quite sensitive. We call it central sensitization. And we hypothesize that central sensitization is a change in the spinal cord where your entire body has become more sensitive. And this can lead to sensitive muscles, which is myofascial pain disorder. This can lead to sensitive joints, including the jaw joints, because you use it so often to eat, so TMJ disorders. It can cause migraines, headaches, and it can also cause a lot of irritable bowel syndrome symptoms, constipation, bloating, diarrhea, chronic fatigue. All of these are factors in central sensitization, and what they really represent is that if we don't find any other causes for a lot of these symptoms, then we believe that this person has increased sensitivity of the central nervous system, brain, and spinal cord that's causing them to respond more so to any type of stimulation that in the past they did not feel pain to. And that's why in some of these patients, when you push against their arm, when you touch them, originally before they would feel only pressure and touch, but now with this increased central nervous system sensitivity, they feel pain. And so a lot of these patients, I tell them that yes, you have this increased sensitivity, your pain threshold is low because any type of stimulation will be interpreted as pain for you, but your pain tolerance is very high because you're tolerating pain, living with it on a daily basis. So when there was the advent of further imaging and technology, we always feel that, oh, further imaging and better imaging will save us and tell us exactly where the pain is coming from. Unfortunately, that's really not the case. We have CT scans, we have MRIs, we have nerve conduction studies, we have all these fancy machines, but unfortunately, with chronic pain and even with lower back pain or neck pain, imaging is inadequate to determine whether it's coming from the muscles, coming from the ligaments, coming from the joints, coming from the sacroiliac joint. It does not help. That is, we're talking about mechanical back pain, not inflammatory back pain. For inflammatory back pain, MRI can certainly be helpful. So when I look at pain and when I deal with pain, I don't just see pain as a singular feature. Pain causes decreasing function, which then causes decreasing mood, which then causes decreasing sleep, which then causes increasing pain. And I think everybody would agree with that. But then there are other factors influencing pain as well. There's work, so work-related stress can influence pain. There's social stress, which can also influence pain. Mental stress, patients who are in ICBC or who are in car accidents, they have litigation stress, financial stress as well can influence the pain. And then you have the pain source, the original source that's causing the pain. And I like to point out that I put the original source outside of this pain spiral or this pain circle, because at a certain point when your pain becomes chronic, you really don't need a source to drive your pain anymore. Your pain is driven by a self-perpetuating cycle of decreased function, and because you can't do as much, you feel sadder and more depressed, and because you feel sadder, you sleep less, and when you sleep less, you have more pain. And it's a self-perpetuating cycle where even if we treat your work, your social stresses, and the source of your pain, if the function, mood, and sleep is not addressed, your pain will continue. And this is how, over time, you can perpetuate into a spiral and you start getting central sensitization or fibromyalgia, where your entire body is painful throughout. So I work at the Change Pain Clinic. We are a community-based clinic. We're not associated with a hospital, and we do a lot of pain management, chronic pain management, and we like to go through it. We like to look at your pain condition as an onion that we can peel the layers back and peel the layers back. And so what we like to do is we like to do it step by step. We like to hit all of the factors that are driving your pain, your decreasing function, your decreasing mood, and your decreasing sleep. And we do it with certain self-management options. We have kinesiologists, physio, movement coach, walking to help with the function. We have education classes on breathing, how to decrease screen time, how to increase your sleep hygiene, and decreasing caffeine to improve your sleep. We give patients strategies to improve their stress and improve their nutrition in hopes so that we can break the cycle and we can decrease the pain perpetuating function. So as I mentioned, we work in layers. We have to look at yourself like an onion, and we have to peel back the layers that is causing your pain or adding to your pain one by one by one until you go down to the center. On the outside, the main issue is low function, poor sleep, poor mood. And we treat that with our educational programs. We recommend supplements, we recommend medications to help adjust those factors. One thing that I have to warn people about with chronic pain is that medications don't really do extremely well in patients with central sensitization or fibromyalgia. Basically, people will feel that they're very sensitive to medications. They require even lower dosage than what is usually prescribed, and they have to increase very slowly for them to tolerate the medication. So we try to use more supplements first to help and try to encourage them to do more activity to help decrease the sensitivity. Then we can add in a little bit of medications, mainly to help with sleep and mood. Medications to treat pain are not very helpful. They have very little evidence for long-term relief. And so we mainly use medications for sleep and mood. In terms of supplements, I usually recommend patients to try magnesium. I find magnesium to be very helpful. If you don't have any kidney disease or low kidney function, magnesium can be quite helpful in decreasing muscle pains. I usually start with 250 milligrams. I like the magnesium malate, and you have to increase it every week up to about maybe 1,000 milligrams. It can cause some diarrhea, which for my patients who have constipation is actually quite good. For those who already have loose stools, they may not be able to tolerate it. You do have to take it for 3 to 4 months before we have any substantial benefit. And patients usually will feel that they sleep a little bit better, their muscle pains and their muscle tightness decrease, and their muscle spasms decrease as well. Other ones that I recommend are PEA, coenzyme Q10, or low-dose naltrexone. Low-dose naltrexone is a compound medication. It's used to block opioid receptors in those who actually have overdose, but there have been some studies which shows that low doses can really help um, with patients who have chronic diffuse pain, especially the numbness and tingling pain that they feel throughout the body. Okay, it can be a bit expensive. The evidence is not very strong, but there is some evidence. Anecdotally, some of my patients respond really good to low-dose naltrexone, especially the pain throughout the body, the numbness and tingling throughout the body. They do have some benefit, and the benefit of these medications are that they very rarely interfere with any other medications you're taking. I've also advised patients to try gabapentin Laricon, mainly for nerve type pain. I like to use antidepressants, specifically Cymbalta or Effexor, or tricyclic antidepressants, mainly for sleep. Cymbalta does have some evidence for chronic pain. It's not very strong, but at least it is something. I've had a lot of patients ask me about cannabis and cannabinoids, and that's an entirely different talk altogether. But I have referred patients on for medical marijuana trial. I believe that in some patients, medical marijuana can be very helpful. I do not believe that patients should be trying medical marijuana below the age of 25. There's been studies to show that if you are below the age of 25 and you do use a lot of medical marijuana, it can still influence your brain development. Health Canada stipulates that you have to be above the age of 18, but I feel 25 is the limit. For patients who don't want to try medical marijuana, I like to use Nabalone. It's a marijuana synthetic marijuana type analog. It's not medical marijuana itself. You can take it to other countries. It's pharmacare approved. Patients actually get it covered by pharmacare in BC. And I mainly use it for sleep because people have improvement in sleep from using Nabalone, and it doesn't interfere with their other medications. I do not use opioids for chronic pain at all. Opioids have no evidence for use in chronic pain after 3 months, and it causes a lot of issues with increased sensitivity, hypersensitivity, opioid abuse disorder, and all that kind of stuff. And muscle relaxants I find not to be as helpful. People feel like it's really drowsy. It doesn't really help that much for their chronic pains. So these are some of the articles that I've used for PEA and for low-dose naltrexone. Again, the evidence is not extremely strong, but overall, I found them to be quite safe, doesn't interact with other medications, and some patients do respond to it. Exercise is very important for people with Eng-Spon and for people with lower back pain that's mechanical. I like to give this sheet, and this sheet details about 17 exercises that you can do on a regular basis. It doesn't really tell you how much to do them for. I usually tell patients do them for about 1 minute to 2 minutes each, and then slowly increase, and they can really help with your mobility. These exercises can also help with your core muscles and your hip muscles as well, that can stabilize the lower back. So I find them to be quite helpful. So once we deal with your function, your mood, your sleep, and we've tried to maximize as much as we can about those sources, about those causes of pain, we then dive deeper and say, okay, where's the pain coming from? And this is when we go back to the original graph where we go layer by layer by layer. Is it the skin? No. Is it the muscle and ligaments? And that would be the next step. So next we look at muscles and ligaments because it is the most superficial, and it's actually the easiest it's actually relatively easy to deal with. We usually do a lot of trigger point injections. Now, I'm not going to go into the semantics and the specifics of trigger point injections, except to say that trigger point injections are used by physiatrists, they're used by pain medicine doctors, rheumatologists, many specialties, and family doctors. And the concept is if a muscle is really tense, you put in a needle, and the process of the needle going into the muscle can help cause a relaxation of the muscle that then breaks a feedback cycle that causes the muscle to be constantly tense. In terms of the evidence for trigger point injections, the main evidence is short-term benefit, it's not long-term benefit. People usually with myofascial pain will feel that with trigger point injections, their pain gets better for a few days, maybe a couple of weeks, and then it ultimately comes back. But what I find trigger point injections to be very helpful for is for those that want to do more exercise, that want to do more core strengthening, but they're not able to get there. Every time they overdo it, their muscle spasms, and they're not able to progressively increase their exercise capacity. And that's where I think trigger point injections come in. I would like patients to do trigger points when they have muscle spasm, muscle flare, so that it can hopefully quickly decrease the spasm, decrease their pain, and they're able to continue and increase their exercise capacity by a little bit. And that's the goal. That's the goal of these trickle point injections. I usually tell my patients that yes, there are cases where people get a few series of trickle points and they get better long term, but by and large, it requires a lot of work on their part as well. It's not just they come here, they receive trickle points, and they're better. They have to put in the work. They come here, they receive the trickle points. When they feel better, they do a bit more exercise. They increase their exercise baseline by about 5 to 10%, so that they have a new baseline, and they persistently continue to do exercise to help treat the pain. And that's where trickle point injection comes in. Some people do different methods with trickle point. Some people use local anesthetic. Some people inject normal saline. Some people inject steroids. Some people inject Botox. In general, it's the prospect, the act of putting the needle in the muscle that causes the relief. Some people do say lidocaine lasts a bit longer, but that's because lidocaine can numb the area for a number of hours. I usually recommend against getting steroid trickle point injections because steroid is not innocuous. Steroid has some side effects, and every time you inject into the muscles with steroid, you're giving that patient a dose of steroid systemically, and that can cause side effects. And additionally, when people get steroid in the muscles long term, it can actually cause muscle atrophy. As well, when patients feel better from steroid injections, we're not sure if that's because of the injection itself or because the steroid can actually decrease your pain. And a lot of chronic pain patients, if you give them steroid, they will feel better. But long term, it causes a lot of problems. So I usually recommend people to do either local anesthetic or just normal saline, so IV fluids, and go trigger point from there. So what if trigger point injections, you do it and the patients still have pain, they don't work, it doesn't even give them short-term benefit, or they feel like the muscle's too tense and they're not able to respond to trigger point injections. Then we go even lower. We look at the facet joints. We look at to see if there's a nerve impingement. That's when we go a little bit deeper. And for those, we actually do interventional injections. Now, different areas do it differently. In BC, most of these injections are done in hospital under CT guidance and under X-ray guidance. At the clinic here, we've been doing a lot of it under ultrasound, and in some cases, it's actually a little bit safer because with ultrasound, you can see the vessels, you can see the nerves, so you don't hit them. Under X-ray, you can only see the bones, and under CT, while it's good and it's great for anatomy, that's a lot of radiation. So we've been doing a lot of ultrasound-guided injections, and the areas that we can inject are usually the peripheral nerve, the facet joints that we talked about before, and sometimes nerve roots as well, but generally it's facet joints and the peripheral nerve. This is basically me injecting into the facet joints, and you can inject facet joints with steroid or with local anesthetic to see if it works. And if it does work, we can repeat the process over and over again to help decrease pain coming from that area. This is a little bit complicated, and I'm not going to go into this in a lot of depth, but some patients who have mechanical back pain that's coming from the facet joints, what happens is we inject the joint and they feel significant pain relief. And they feel significant pain relief for a set amount of time, and then when the local anesthetic wears off, the pain comes back again. And when we do it every time, they have the same amount of pain relief, 70, 80% pain relief. For those patients, we want to give them a procedure that can last a little bit longer, and so that they're able to live with decreased pain in that area for a longer period of time. Injecting steroids lasts about 2 to 3 months, and even then it can be difficult because there a lot of times the facet joints are so tight and small, it's hard to put a needle inside. And so that's why there's a procedure in pain medicine where we can actually burn off the nerves that supply these facet joints. Now, I know it sounds scary, but it's actually not. Burning off the nerve is actually about 15 to 30-minute procedure from start to end. And the procedure itself only lasts for about 5 to 6 minutes. It's not surgery. We don't cut you open, but we actually put in a needle, the size about just a little bit bigger than the size of your biologic injection needle. and we heat it up to about 80 degrees, and we burn off the nerve in that area. So burning off this nerve will not cause any numbness, will not cause any weakness. It will just take away pain coming from the facet joint. And unfortunately, if we burn it off and it works well, you could have decreased pain for up to a year. Unfortunately, after a year to 2 years, the nerve can slowly grow back. These small nerves, they do grow back and your pain may come back. But definitely in that 1 year, I've asked patients to continue with muscle strengthening and exercise. And when patients have pain coming from the facet joints, they are limited in their exercise capacity. And when we burn off the nerves and give them prolonged benefit for a year, they're able to increase their exercise capacity substantially, especially if they work hard at it. And when the nerve actually does grow back, their muscle strength is so strong that their pain does not come back the same way as it did before. And that's our goal. So what if these ultrasound-guided nerve blocks and joint injections don't work, or they cause a lot of pain flare and patients are not able to withstand it? In that case, then we diagnose patients with what I mentioned earlier, the central sensitivity, where the central nervous system have become very sensitive. And this can be very difficult to treat. A lot of it relies on mindfulness, cognitive behavior therapy, counseling, certain medications to help with function, mood, and sleep, and slowly, progressively increasing your exercise tolerance from a very low level and slowly moving up to a higher level. And this can be quite difficult to treat. In very severe cases where we have run out of other treatment options and the patients are sensitive all over the body, we have tried infusion therapy. Infusion therapy is basically where it's exactly as it sounds. We infuse a patient with a significant amount of lidocaine or ketamine, and the point of the infusion is to numb your entire body for a set amount of time. And then when your body kind of resets and the medication wears off, hopefully the amount of pain in the central nervous system does not come back to the same severity as it was before. It's like taking the computer and just turning off the computer and then turning it back on again. Does it work in patients with chronic pain? Normally, infusion therapy is for people with neuropathic pain or nerve pain. In some cases, we have used it in patients with chronic pain, fibromyalgia, and soft tissue pain. The effect is variable. Some patients respond really well, others respond somewhat well, but require more and require ongoing infusions. There is one site that offers free infusion in BC, and that's in the hospital. There is another site we do the infusions as well, but we do it on a private pay basis. We're not covered by the health authority. And so that is a big barrier to a lot of our patients. So that was kind of a whirlwind tour of how at the pain clinic we deal with chronic pain. And definitely it doesn't work for everybody. But if we go by a layer approach, an anatomical approach, and we understand the complexities of chronic pain, we can certainly help patients get their function back a little bit. And that can go a long way in terms of decreasing their mood, improving their sleep, and then decreasing their pain. Any questions?
Thank you so much, Dr. Sun, for this great presentation. I don't know if we can start the videos again. I think you answered like a lot of questions that came from the audience, especially for the ketamine injection. That's something that I didn't know, so very interesting. However, one of the questions that might also be interesting is the patients, how like you're a doctor, they come to your clinic, so how can they communicate with you their level of pain without being some sort of a drug seeking patient?
That's a very complex question because it involves a lot of different layers. You're talking about a patient who comes in who is like on opioid therapy, who likes to continue on opioid therapy, but doctors are very hesitant in opioid therapy, and they don't feel that the doctors believe that their level of pain requires opioid, right?
Mm-hmm.
That's basically just the question. That's sensitive topic right now, mainly because politically it's very sensitive. There are a very, very, very small proportion of patients who can be controlled with regular dose of opioid therapy for their pain. Opioid therapy usually never recommended for chronic non-cancer pains. And the reason is because if you look at the studies of opioid therapy, long-term use, they are effective in the term, but long-term, they're just associated with so many issues. And I've seen a lot of patients with non-cancer pain where they're on opioids, and over time, they require more doses. Or if they've been on opioids for a long time, their pain sensitivity actually increases. In terms of talking to doctors and to know that you're experiencing pain, certainly pain is a subjective feeling, the subjective phenomenon. It is difficult and almost impossible for us physicians to know exactly how you're feeling, exactly how bad your pain is, because it is everybody will feel differently, and everybody will be impacted their pain differently. So my advice to patients is, please, when you go in to see your doctor, with the expectation that even if you tell them about your pain, they will not be able to understand exactly how bad it is and how much it's affecting you. That you're talking to your doctor about your pain, I think that it's important to basically just voice to them, doc, this is how it's kind of affecting my function, affecting my life, and this is how often I feel the pain. This is how these medications does help me or do not help me. I think for opioids, you really have to be careful. I have given people opioids. I don't prescribe opioids myself, but I have had get opioids, and I've supported their GPs and given them opioids if they have either a of pain. For example, they have hip pain and they're waiting for surgery, and they're just getting through that hip pain and waiting for surgery to fix it, or they've got this nerve pain that just never stops, and they're on the same dose of opioids for the last few years, haven't had increased pain sensitivity. They use less than what their opioid therapy. In some of those cases, they're very stable. I have supported the GP in giving them opioids, but by and large, I've always asked people to try and taper off of their opioid. And those who've been on opioids for a very long time will generally feel that when they taper off the opioids, their pain increase will be very bad for the first 10 days, and then it'll drop off. And then if it hasn't really gotten worse compared to before. And those try to drop as possible, and the sensitivity goes down as well.
Thank you so much, Doc. They are like questions. Just to resume, even with patients without opioids, is it like useful to have a journal or some sort of a scale that we're trying to develop now at the CSA, just like to give you an idea of our current level of pain?
Yes and no.
Just if you could, because like we have like your topic is like on fire, so we're gonna try to answer all the questions, but
I'll keep it quick. Yes. Yes. If we do an injection or a procedure on you, and we need you to monitor how your response is, so that we can determine whether the procedure is successful. If you're doing it on a general basis, no, it's not good to do that. What happens is, if you focus on the journal all the time, you're reliving your pain in your mind all the time. You're focusing too much on your pain, and that's not what we want. So I would suggest against it.
Okay. All right, thank you. Great topic again. So what about the diet? So I'm trying, like, frankly, I'm trying some sort of a low sugar diet, and to be honest, it's working for me. I don't know if it's something that's mental, but I don't use sugar, alcohol. I get flare-ups and less pain. What do you think about that?
So that's actually a very good and very, very complex question. Let's separate it into two parts. Let's separate the chronic pain and inflammatory pain. Patients with ankylosing spondylitis and IBD, there are studies now to show that diet may have a difference, although the studies are not very strong. Recently, there's been studies that a Mediterranean diet may decrease inflammation. There's a Dr. Wells anti-inflammatory diet, WEILTCS, and some people have had benefit from that. Some people say that with gluten helps them. Others say take away gluten doesn't. Like you said, it's very personal, it's very subjective. But in general, if you follow a Mediterranean diet, lots of fruits and vegetables, decrease your intake of burgers, processed foods, red meat. It can decrease inflammation and help with inflammatory pain. For chronic pain, studies are even less strong because chronic pain is a very hodgepodge of different things. I usually advise patients to do the same thing as the anti-inflammatory diet. So far, that's been the most difference in terms of changing your inflammatory gut. Other colleagues, they follow other diet regimen, but in general, the concept is the same. Mediterranean diet, veggies, fruits, decrease red meats, decrease beer, seafood, and processed foods. And also, if it helps you with weight loss, also help with chronic pain as
well. We also have a question about mushrooms, like reishi. Yes. Any thoughts on that?
I don't have any knowledge about that. I think will be on a case by case basis.
So we also have like a pretty interesting question. As you said, like pain can be very complex. So how can patients trust their doctors to identify the right source of difficult one? So
yeah, that's an interesting question. As I showed in my presentation, when you have chronic pain, the source becomes less of an issue, and the other symptoms that can perpetuate pain, for example, the mood, the sleep, the decreased function, becomes a much bigger issue. I generally tell my patients this: if it's inflammatory type pain, we have imaging and we have technology to deal with the find that. I have a lot of patients that come to me and say, "Hey doc, I want another MRI. I want another CT scan. I want to see what's going on." And 99% of the time, actually, 99.9% of the time, we do not find anything that changes our treatment. And I like to tell patients the following: look, you've had chronic pain for a number of years. You've gone through and this and this and this many investigations. And usually when they come to see me, they've seen neurology, physiatry, orthopedic surgery, rheumatology. Nothing really comes up. We are at the limit of our medical technology in terms of finding out where the source of your pain is. And to be honest, the source of your pain right now is less issue than the other issues that's perpetuating your pain. It's like you are going in a road and you are stopped at a fork in the road. On the one hand, you can continue going to different clinics, going to Europe, going to the US, anywhere, pay money and do further investigations to find out the cause. And they may be positive and you spend money and go through treatment and it may not work. But what I can tell you is the other road is that anything that's causing you damage, anything that can be damaging your organs, anything that can kill you, we've basically ruled out with all of our investigations. Our technology is not good enough, may not be good enough to find out exactly what's the cause of your pain, but we've ruled out stuff that will shorten your life. So we will keep on looking if new things show up, if new technology comes up. But the other role, why don't you start chronic pain management right now? And as symptoms do come up, we can keep on investigating. We're not going to help, but you shouldn't wait any further to start pain management for another cause. And some patients do to go on with treatment, but others do not. And it really depends on how ready they are to accept the fact that they need to treat their chronic pain instead of being a cause of chronic pain.
I love it. I love this notion of trying to start managing our chronic pain and waiting to see if we could find the source. Another interesting question. So, if it's on biologic, like example, but I don't feel the pain. Does that mean that the biologic isn't working, or is that arthritis pain cannot solve 100%?
So that can be very difficult to tell. I've had patients where they're on biologics, and when you do CRP, the CRP is very low, and when you do MRI, no signs of inflammation. Okay, but then sometimes I switch another biologic, and suddenly their residual pain goes away. And in those cases, we can assume that it's because there's still some inflammation causing pain. It's not completely controlled, but the inflammation is so low that it's not causing any damage on the MRI. It's not causing an elevation in the CRP. And so the answer is, I'm sorry, I really don't know, because it really depends on your situation. And the only way that we can tell is if your CRP is low, your MRI is low, how bad is your residual pain? If it's bad enough, maybe they'll switch to another biologic. If it's not that bad, then maybe try to manage it with anti-inflammatories, okay, exercise. Sometimes maybe we could do a steroid injection into the sacroiliac joint, and that may help some patients as well. So we can look at other options, trigger point injections to decrease the residual pain.
Awesome, awesome. Thank you. Have you prescribed patches for patients? Do you
So pain
recommend that?
patches have very limited. Yeah, pain patches I have. Pain patches have very limited use. Pain patches are mainly used for nerve pain. So, for example, shingles, post-herpetic neuralgia shingles pain, nerve damage pain. They don't work extremely well because the absorption of pain cream and the pain is actually very thin. So, yeah, if the area where you have pain, for example, is a joint pain, and you've got a layer of tissue on top of it, like a layer of fat or tissue, it's not going to get absorbed. So that's why it's mainly for superficial pain, and even then, it doesn't work quite well. The other issue with pain patches is I use pain patches in children when I want to numb skin, so when I do an injection, they won't be tired. But you have to keep the patch on for a very long time. They wear off, and sometimes it rashes. So while it's for certain uses, I don't use it very often.
All right, and another question, like 2 more questions, then we're gonna close it off. So this one, I think you already answered it, but it's coming also. So a patient with neck pain, and he's actually wondering if it could cause him chronic head.
Yeah, so definitely can. And we call that cervicogenic headache coming from a neck source. Most commonly, it is the back of the, and you can move up to the apex. It can be coming from different structures. So sometimes neck muscle tension can radiate pain to the back of the head. Sometimes the neck tension can actually compress the nerves that innervate the back of the head, causing numbness, tingling, and pain. Sometimes points in the upper neck be aggravated, and that can also radiate pain to the back of the head as well.
Last question is more about like mental health and anxiety, stress, its relationship with this or spondyloarthropathies. So how do you manage that? Do you refer them to a psychologist? And do you openly start Cymbalta? You said so. What's your experience with that?
So for patients with psoriatic arthritis and ankylosing spondylitis, depression is more common, more prevalent, and a lot of times underdiagnosed. In these cases, I usually try to get patients to see a counselor, a clinical therapist. If their symptoms are mild, I usually try to send them to a psychiatrist. Cymbalta, I usually don't use them. I use more for chronic pain and depression stuff. It's more for pain management than it is for depression. I do have a number of patients with psoriatic arthritis on antidepressants, and generally, it's quite tolerable.
Thank you so much for your time. The presentation was awesome. I really hope that everybody got her questions answered. We're gonna keep the recording on the website. Please do subscribe on the website. Follow us on the social media. Do also emails if you have any more questions. And please do fill the survey just in order for us to get better next time. Thank you so much for joining us. Thank you again, Dr. Sun. That was amazing. And
my pleasure.
have a
Thank you so
great
much.
evening, everybody.
Thank you, you too.